Okay. Come to the first HROC, 628. Since it's a new committee, I'm calling it to order, and I will immediately turn it over to the members to organize the committee.
So I'll jump in. From some conversations, my understanding is that there's been somewhat of a tradition of going back and forth between the House and the Senate in terms of chairing HROC, and given that be the case, I would move to nominate Representative Hooper to chair the committee for the next period of time.
Second.
So Bill, why don't you, or somebody should ask.
I'll recommend a nomination cease, and we don't have a secretary, but that we would cease nominations and vote on the nomination we have on the floor. So I think, Nolan, you're still presiding until we do this. So would you please call the vote?
Apologies. Okay, so okay, so I walk to the members. I've never called a vote before. Okay, let's just go by the order of this.
I don't know if it has to be roll call. It could be just a voice vote.
Okay, all in favor of the motion, please say aye.
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 All opposed? The motion is carried.
Okay. All righty. So thank you, folks. And I understand that the tradition is that there is not a vice chair. So with that, let us just get down to the order of business, which is to begin with a presentation from from joint fiscal office from Nolan Langweil, and also from Jennifer Carby, about just giving us a grounding on the global commitment process and the alternative payment model. And then at 2 o'clock, we're going to hear from our friends at AHS about again, an overview of the payment, of the waiver and the payment agreement, and what is being proposed for reauthorization. And we'll do introductions of our friends from over there at that point. So by the agenda order, and so our purpose is just to get grounded today on the issues that we may wish to consider, and then maybe at the end of the meeting we can take a few minutes to discuss what our next steps should be. And so judging from the order on the agenda, Ms. Carby, do you want to go first? Are you first up in this presentation?
Nolan and I are actually going to present together.
Together, all righty. Yes. So please go ahead.
Great. So for the record, Jennifer Carby, Legislative Counsel.
And for the record, Nolan Langweil, Joint Fiscal Office. Share screen. Can everybody see that?
Yep.
All right. Awesome. So yeah, as Jen said, we're going to kind of tag team this presentation. And the purpose of this is to give just a very high level overview of global commitment and then the all-payer accountable care organization model agreement. That's a mouthful. I'm just going to call it APM from here on out. But and of course, Jen, of course, just hop in at any point. This slide really, one of the things that happens is constant people, legislators, non-legislators are often conflating the global commitment waiver and the all-payer model agreement. So the purpose of this is to sort of like do a high level and talk about the difference of the two. Even though they're very separate, there is a strong relationship, and we'll talk about that too. And then any specific, we would ask though that any specific questions you have about how they're meeting targets and plans, that you would hold those questions for the next presenters, because they're the ones who will have the answers about the specifics of how it's going, numbers, attribution, etc.
And Nolan, I'll just jump in here to say there was a question about whether this is available. It is on the Healthcare Reform Oversight Committee page on the Joint Fiscal Committee website. So under the supporting documents, it should be the first one.
Thank you.
So we'll start with global commitment. And just real quick, the global commitment is our 1115 demonstration waiver. We'll talk about what that is. And the all-payer model is multiple payers, Medicare, Medicaid, and commercial. And the goal of that is to move from fee for service to value-based payment with overall targets and outcomes. So again, this is a high-level presentation. So we'll start with global commitment. And the purpose of this is I just want to have some context of showing how our overall spending is, how much spending on healthcare is Medicaid. And 27% of all Vermonters spending is Medicaid. And about 90% of our Medicaid spending is through the global commitment waiver. There's a small percentage of stuff that are not through the waiver. That would include things such as DISH, which stands for disproportionate hospitals. That's payments we give to hospitals, that's matched. There's clawback, which has to do with Medicare Part D, where the state has to pay some money back to the feds. There's a CHIP, which stands for Children's Health Insurance Program, which is a separate program. Those kids fall under our Dr. Dinosaur program. Our exchange cost sharing subsidies are also are not matched. And then we have some state-only prescription drug programs. Again, I just threw this in for overall context, just to give you a sense of how big the Medicaid budget is relative to the whole spending.
Can I jump in and ask if somebody can send a link to the presentation? It's much easier for me to see it on my iPad. Thank you.
Yep, I just sent it out.
Thanks.
Apologies, I can't see the chat, so
I'll keep an eye.
Thank you. And you want to do this?
Sure. So Global Commitment to Health is the full name. We call it Global Commitment for short. And that is the name of the agreement between Vermont and the Centers for Medicare and Medicaid Services, CMS, that is used to administer the majority of our Medicaid program. As Nolan was describing, there are some things that are out. Under Global Commitment, most of Medicaid is operated through a managed care-like model. And Vermont is unique in that DVA, so a public agency, acts as a public managed care entity. Many other states do manage all or part of their Medicaid program through a managed care, Medicaid managed care arrangement, but those are with private companies, organizations. Vermont's is through a public managed care organization. And Global Commitment is a Medicaid Section 1115 demonstration that refers to Section 1115 of the Social Security Act. And that provision allows the federal government to waive a number of the laws around Medicaid, including those relating to eligible individuals, so who's covered, and eligible services, what's covered. This Section 1115 authority is meant to encourage states to innovate in how they design and improve their state Medicaid programs. And a state can have more than one Section 1115 demonstration project or waiver agreement with CMS at the same time. 40 states have at least one of these. And the bottom line under this 1115 waiver is that federal expenditures for the state's Medicaid program under the waiver, so what we spend with the waiver, cannot exceed the federal expenditures that would otherwise have been made without the waiver. So it has to be what's called budget neutral to the federal government.
Excuse me, Ms. Carby, let me interrupt. Representative Ansel still hasn't received that. You may want to check which email you are sending that to.
Well, I sent it to the Health Reform Oversight Committee email page.
I got it.
Yeah. Which has the wrong email address and also the wrong Hooper. So somebody may want to look at that. Representative from Randolph may be surprised by what just appeared in his inbox.
Yeah.
All right. Let me send this. Try sending this one more time. All right. Hopefully that will do it.
Thank you.
Sure. Nolan, do you want to do this one or do you want me to do it?
Why don't you continue this one?
Okay, you're about to get into the money part, I think, so I'll do this. The global commitment terms and conditions, which is a large part of the waiver documentation, those set forth how the program will be administered, including who is covered and what what services are covered. And as through our waiver, the state identifies ways to save Medicaid funds, and then we are allowed to use those savings for certain identified priorities or goals. Some of the goals are written directly into the terms and conditions. Others are achieved through what are called investments, and in the past used to be known as MCO investments, now are just called investments. In FY 2020, Vermont had 69 investments worth approximately $124 million. That includes the federal match. Without the waiver, those would all have either required state funds to pay for them, or we wouldn't offer them, wouldn't be able to offer them. These were initially known as costs not otherwise matchable, or CNOM, but I think that acronym has gone by the wayside. And there is a link to the list of investments that can be found on the legislature's website. And that's part of a requirement that every year AHS provide a list of the current investments under our global commitment waiver.
For those of you who've seen it, it's in like 2-point font. It's very easy.
Small. Don't print it out, just blow it up on your computer.
The purpose of this slide I threw in was to just give folks a sense of how much of Medicaid, again, is under the waiver and how much is outside the waiver. So this is really just a visual. When we say plan services, we're really talking about traditional services and everything else. And then you can see the 91% of our Medicaid program is under global commitment, and the rest is outside of global commitment. So here's just a history. We just tried to kind of highlight some of the bullet points of what was in those and what were some of the changes. Again, high level. So initially, global commitment started in 2005, and it was 5 years. Normally, they're 5-year waivers, and then they can be renewed for anywhere between 3 and 5 years. So when it first passed, most of Medicaid operated through a managed care-like model. AHS paid DIVA, which was then OVA, a member per month capitation rate to cover Medicaid expenditures. If DIVA kept those, OVA kept those expenditures within the capitation rate, then the state would accrue savings that could be used to make expenditures for the following purposes. They could be used to reduce rate of the uninsured or underinsured, increase access to quality healthcare, implement public health programs to improve health outcomes and quality of life for Medicaid eligible individuals, and or encourage formation and maintenance of public-private partnerships. So these were under the terms and conditions, and under the most recent version, these are similar. The newer versions of these have been sort of expanded and tied a little bit more to what the more recent initiatives are, but I won't get into that. We had a global spending cap, which was for the whole duration and not on an annual basis. So it would be a total amount that we would spend over that period of time within the cap. We expanded some access to Medicaid coverage. And then in 2007, there was a waiver amendment. We can do amendments to the waiver during those times. And so waiver amendment happened that allowed for the implementation of the premium assistance programs for eligible individuals under Catamount Health. Initially, that was for folks up to 200% of federal poverty, but then it went up to 300% of federal poverty in 2009. So in short, we were giving subsidies to folks under 300% on the Catamount Health Plan, and we were getting federal match for that. 2011 to 2013 was the first renewal, and there were some minor changes to the managed care model, but essentially it retained the ability to use the savings to make investments based on existing categories. There were some fiscal changes to the draw of federal match that was tied back to actual expenditures instead of capitation, instead of capitated PMPM. So we still estimate what the PMPMs will be, but it's tied back to actual expenditures. And in 2014 to 2016, many of these amendments were based on coverage changes to the Affordable Care Act. So effective 14, let me put Steve in. In 2014, there was elimination of, actually, Jen, do you want to do this since you wrote this piece?
Sure. So 2014, they, we as part of the waiver eliminated provisions relating to VHAP, which was the Vermont Health Access Plan, and to Catamount Health. Those were two programs that were no longer compatible with after the Affordable Care Act was implemented, and the implementation date, as you may recall, for the exchange plans was 2014. So there's kind of an off and on switch there for these programs. So eliminated the VHAP and Catamount provisions. It added the new adult Medicaid eligibility group, which is the people between 100 and 138% of the federal poverty level. There's sort of a quirk in the way it's written that it actually goes up to 133% of the federal poverty level, but then there's a 5% income disregard in there. So the result is 138%. It also added Vermont premium subsidies for eligible individuals. So these are people with income up to and including 300% of the federal poverty level who purchase qualified health plans through Vermont Health Connect. So we used to have that Catamount premium assistance for people up to 300% of the federal poverty level. That went away when Catamount went away, but we were able to get the federal government to provide the match on our Vermont only premium subsidies, which are in addition to the federal premium subsidies that are available to people up to 400% of the federal poverty level. And then also in 2015, the Choices for Care, which was its own separate waiver, Choices for Care, which is the home and community-based services provisions for people who might otherwise need a nursing home level of care, was consolidated into our global commitment demonstration. So instead of having separate waivers to administer, they were consolidated into one.
Screen is frozen.
Can I ask a
No.
question, or do you want me to wait till the end? A question of clarification.
Yeah, go ahead.
For the chair.
Yeah, on the Choices for Care, Jen, did that add any additional funds into our 11-15 waiver, or was that, did the cap remain for what cap was in place as a result of that integration?
I'm going to look to Nolan for that. That sounds like a money question.
I'll actually defer to Sarah Clark if she's listening.
Okay.
Hi.
There we go.
Yes, that reflected a consolidation of the two waivers into one, and so the budget neutrality was combined.
Does that mean that Choices for Care was an addition to the initial waiver, 11-15 waiver, or not?
The Choices for Care expenditures
Did it
were
add money?
consolidated underneath one 11-15 waiver.
So I
that
think
raised
the answer
cap.
to your question, Senator Lyons, is
Yes.
that the cap became an overall cap that incorporated both pieces. So we didn't get additional expenditure authority beyond what we had. We just had it all under one single waiver. Sarah, is that, correct me if that's not right.
Okay,
Thank you, Jen.
Does that answer your question, Senator Lyons?
I think so.
Okay, let's keep going.
So 2017 to 2021, this is our current term. So in the most current waiver, which ends at the end of this calendar year, we are still under a managed care-like model, same as the previous periods. However, CMS designated DIVA as a prepaid inpatient health plan for services and populations covered under the waiver, which essentially is a Medicaid managed care designation for how the state will be regulated and the rules, requirements, and standards the state must adhere to. Now, it doesn't sound like a big deal, but essentially what this is a designation for how this, like, it's sort of narrowing in like how the state will be managed under a definition within CMS. And if you have more questions about that, again, I will defer to the folks in the administration to go into the detail of that. But that was an important piece that I was asked to include. Also, there was new stricter requirements regarding spending on investments. So now the state can only spend dollars on specific programs and services that are approved by CMS. It used to be that if we felt it felt within those 4 definitions that I mentioned earlier, that we could just do it. Now there's a much tighter parameters about what it is that we can and cannot have investments on. And then on top of that, the total amount of permitted investments have gradually reduced each year over the 5-year period as the federal government's tried to rein in what we're doing investments for. This is where there's some overlap between the all-payer model and global commitment, but in the language, it allows for delivery system-related investments to support the implementation of the all-payer model ACO. At the time that this was passed, the agency was also negotiating the all-payer model. They were negotiating two separate agreements at the same time, so they tried to make sure that there was room within the global commitment to be able to use some of those dollars for implementation. And then in 2018 and 2019, there were some amendments to waive the institution for mental disease, otherwise known as IMD exclusion, for short-term residential and inpatient treatment services for substance use disorder and serious mental illness. This is, and the administration will get into more detail on this, but this is the timeline for what the administration released in May in terms of what they expect the renewal process to look like in terms of public comments, drafting, negotiations, et cetera. So I'll just do this in really as a visual, but the administration will talk more about where they are and what it's going to look like. Jen.
Yes, and then we get to your role, the legislature's role. So, the Agency of Human Services administers Vermont's Medicaid program, and that's pursuant to both state law, where they're directed to do that, and federal law, which requires states to identify a single state agency for Medicaid purposes and to administer the program. And AHS, Agency of Human Services, is Vermont's. There's also a provision in our statute that specifically requires the Secretary of Human Services or designee to seek approval from the General Assembly prior to applying for and implementing a Medicaid or SCHIP waiver or waiver amendment. So they needed approval from the legislature to pursue this renewal. And that's what you did in section E 301.1 of this past year's budget bill, which authorizes the secretary to seek to extend or renew the global commitment demonstration that is set to expire at the end of this year. And in that language, you said that the agency must strive to maintain or increase the state's flexibility to use global commitment investment dollars to increase access to care and coverage, improve health outcomes, strengthen healthcare delivery, and promote transformation to value-based and integrated models of care. So that's the language from our existing waiver in the areas that we can use the investment dollars for. But this is looking to potentially increase our flexibility because, as Nolan had noted, that's been getting decreased over recent years. And then in a larger view, the General Assembly provides oversight of the Medicaid program and the Medicaid and through the global commitment waiver. So as it's administered through the global commitment waiver by getting updates from the agencies and answers to questions. You also appropriate state funds for the Medicaid program, which can have the effect of limiting or affecting what money gets spent on. And then you have at times directed the agency to seek waiver amendments as needed to implement certain legislative policy decisions. So things in that bucket are things like the Catamount premium assistance and the qualified health plan premium assistance. So that is the end of the quick global commitment overview. Are there any questions before we move on to the all-payer model?
I can't see the screen, and so unless people are raising their hands or gesturing, please jump in. And if they're not, I think it's safe to move on. Ms. Carby.
Great.
So folks will have a chance to ask more questions of the administration too. So, so part two, the all-payer accountable care organization model agreement. Again, we're going to do a very high level of this. Actually, Jen, you want to do the legislative history?
Yes, so we're starting out here with the legislative history. Back in 2015, the legislature required the Secretary of Administration and the Green Mountain Care Board to jointly explore an all-payer model. This was something that had been sort of talked about, and so there was legislative directive to jointly explore that and see what that might look like. And then in the following year, the legislature passed legislation allowing the Green Mountain Care Board and the Agency of Administration to enter into an agreement with CMS for a Medicare waiver, which was going to be part of this all-payer model. So allowed them to enter into an agreement for a Medicare waiver only if the agreement met certain conditions. It had to be consistent with the Act 48 principles. It had to preserve Medicare consumer protections. It had to allow providers to choose whether to participate in ACOs, allow Medicare patients to choose their provider, so to still allow them to choose any Medicare participating provider. It must include outcomes for population health, and it must continue to provide Medicare payments directly to the providers or ACOs. And this was to address a particular concern about the state having control over Medicare funds. So again, this is specific to the Medicare waiver, which was always intended to be part of the all-payer model, but a Medicare waiver is a more recent development aside from the Medicaid waiver that we've had for a number of years. So then continuing on in that same 2016 Act, you created a new statute that codified the parameters that the Green Mountain Care Board and the Agency of Administration had to ensure that an all-payer model would meet. And some of those are similar to or the same as the ones specifically around the Medicare waiver, but there were some additional ones as well. So this all-payer model had to be consistent, again, with the Act 48 principles, had to maximize alignment among the payers, so trying to get the payers operating under the same processes, had to strengthen and invest in primary care, must incorporate the social determinants of health, must provide a process for integrating community-based providers, must allow providers to choose whether to participate in ACOs, and it must evaluate access to care, quality of care, patient outcomes, and social determinants of health. This is not an exclusive list. There are some others, but these were some of the big ones. The same act also created the framework for the Green Mountain Care Board to have oversight of accountable care organizations through an annual certification process and an annual budget review. And there have been several amendments made to those processes since 2016, where the legislature added additional provisions that either gave the Green Mountain Care Board greater oversight over certain aspects of the ACOs, or attempted to drive some of the behavior of the ACOs themselves.
So the all-payer model signatories are the governor, the secretary of the Agency of Human Services, and the Green Mountain Care Board chair. Two of those folks that will be signing it are on this particular Zoom call. It's done by performance years. So that's what the PYs stand for. And it's 12-month periods between January 1 and December 31st. And so 2017 was plan year 0, and that was sort of a rev up year. So they get moving. And then plan year 1 was 2018, and it's going to go through 2022. We're currently in plan year 4. In calendar year 17, there was some startup funding, which was 9.5 million. And for anybody who's interested, we included a link to the agreement for anyone who wants to read it. Senator Kitchell, are you raising your hand?
No, I'm not. Sorry.
Okay. So the goal is mentioned earlier is to shift from fee for service to a value-based reimbursement model with targets for spending growth, population health, and care quality. So the spending growth targets are that it will be no more than 3.5% average per capita per year across all payers, all which are the Medicare, Medicaid, and commercial between 2018 and 2022. However, there is a ceiling that will cap it at 4.3% increase per capita per year. Medicare has a slightly different, it would be 0.2% below national projections. That's the target. And then we have scale targets. And so those are annual attribution targets. And the goal is to get 70% of the population enrolled into the model by 2022. And it would be 90% for Medicare. So I've included a little chart that shows what the scale targets were between 2018 and 2022. I couldn't tell you where we are currently. Representative Pugh.
I may be late to the party. I note that Medicare, the spending growth target is less than national projections. We have one of the oldest populations in the state, in the country. I'm not quite sure. How does that make sense? And who makes those projections?
I would defer to the administration to answer those questions since they negotiated it.
Do you,
I think Nina's answer it.
yeah, hi, Ms. Backus. Do you want to jump in on that?
Good afternoon. The Vermont does have an older population than other states. This spending is measured based on the Medicare growth year over year per person. So it's individual, it's a per member growth target rather than a population aggregate spending growth target.
So what you're saying is that we're going to assume that we're going to spend less on senior citizens and people with disabilities while we are allowing for an increase in spending for other people. You don't need to comment. I'm just getting to understand this.
Is a clarifying point necessary here?
It's growth target though. It's not a distribution.
And it's also not a decrease. It's just that our growth would be 0.2% less than the national growth. So we're not having a reduction in Medicare. The goal was to spend less than the national average per capita.
And
So-
Medicare spending has been growing faster than the 3.5% nationally. So I don't think it's pitting one group of citizens against another, but I understand Representative Pugh's concern. It's a well-founded one.
Yeah, okay. Thank you. Let's kind of put a pin in that and continue through this.
Okay, and then the other part is about improving health outcomes, so that in some of the targets that have been included in the all-payer model deal with reducing drug overdose deaths, lowering the suicide rates, reducing incidence of chronic disease, and increasing access to primary care. This slide really is illustrative. It's just to give a sense of people say, well, how do we measure these different things? How do we know if we're meeting our targets? And I just threw this slide in, it's just to give a sense of the types of data that they are going to be using to report. So how we know if we're meeting our targets or not. I won't go through this slide. I just threw it in there for illustrative purposes. And also for time's sake, I threw this one in. Again, I'm not going to walk through it. It's really just a visual. This visual, I believe, was created by Michael Costa several years ago when he still worked for the administration. And it just meant to just be a visual to give like a visual of how the different payers pay in, the role of the accountable care organization. But for time's sake, we are 7 minutes over. I'm gonna just end there.
Okay. Thank you. And that is the end of your presentation? I'm sorry, there we go. It must be. Thank you. Lots of things to ask questions about, but not the time to do it. So let us turn, and Secretary Smith, why don't I turn this portion of the meeting over to you? I'm not sure if you've coordinated. We're very much appreciative of the staff from AHS who has come in to join us, and also very much appreciative of Mr. Mullen and Ms. Barrett from the Green Mountain Care Board for joining us. And I just want to leave some space for their comment, their participation in this discussion. But let me, with that, turn it to you, Secretary Smith, and ask you to guide us through this.
Sure, and thank you, Madam Chair, and thank all the committee members. I really want to thank you for the opportunity to be here to talk about our healthcare reform objectives and the federal partnerships that rely on continuing to make changes as we move forward. I will apologize. For some reason today, I'm starting to lose my voice to the enlightenment of staff. They really are happy about this, but I don't know what's going on, but I'm losing my voice. We'll be providing an update on our progress to renew both the 1115 waiver and separately a look at the subsequent all-payer model agreement. It was in 2005, a then Secretary of Human Services said, hey, you know, let's do this. Let's ask the federal government to give us wide latitude in trying to come up with savings in our Medicaid program, and then use those savings to invest into back into the Medicaid program. And that I was trying to remember how we came up with the global commitment name, and I just can't remember how we came up with it, but we named it global commitment. And at a high level, our 1115 proposal is seeking this year to preserve the flexibility that we have today to innovate in both payment and delivery of health and human services, but also preserve the flexibility that we once had and need to have in order to make improvements to population health improvements as a state as a whole. You remember, as you saw the slides, federal government has sort of been chipping away at that flexibility over the years, and we would like to sort of regain some of that flexibility. Our 1115 waiver serves programs, and you're very familiar with a lot of these programs: Blueprint for Health, workforce development, and public health infrastructure. And it's had some pretty good results. Vermont has nearly universal health coverage, as one of the healthiest populations in the nation, despite being one of the oldest populations. And it serves nearly 60% of enrollees eligible for nursing facilities care, not in nursing homes, but in home and community-based settings. And to maintain our flexibility and authority to support these population health improvements, we're proposing that DVA serve as a risk-bearing Medicaid managed care organization, as it once was, instead of into this sort of limbo land that they put us in terms of a category since 2016. And if we are successful with this proposal, ultimately we will want to explore whether DVA could do the same for Medicare. That would be in the future. We could do this through a linked all-payer agreement with Medicare. This could allow us to more effectively address the needs of Medicaid and Medicare dual eligibility and have some flexibility to pay differently on behalf of Medicare. I also want to talk about the all-payer model, which is closely linked, but is a slightly different timeline. The all-payer ACO model will finish up its demonstration period at the end of 2021. Remember, the global commitment waiver is finishing up in 2021. I'm sorry, the all-payer model will finish up in 2022. The global commitment will finish up in 2021. I've asked that we look at a potential one-year extension of our current model of all-payer model through 2023 to get a better evaluation of what is going on with that model. I want to be clear, and I've been very clear about this with most of the provider community. I'm committed to moving away from the fee-for-service reimbursement system for healthcare services. I've been committed to do that since 2005. Today, the healthcare system operates to make money on each additional and more costly procedure. And even if a person isn't better off, instead of and it's perverse in the way that this model, this current fee-for-service model works. The more procedures, the more visits that you make, the more money that you have, the more money you make. And I really want to, instead of that payment model, We need to give a system that's more predictable from a budget and upfront money so that we can really focus on keeping Vermonters healthy instead of ringing up the tab. At the highest level, this is called, and there's various things you can call it. I call it a value-based payment. The all-payer model agreement helps us to make this change meaningful by aligning these types of health coverage that Vermonters have. That means aligning the commercial insurance, Medicare, and Medicaid into this new payment model, this value-based payment model. The idea behind the all-payer is that if all three major payer types of health coverage pay the same way and commit to improving population health, then providers have consistent initiatives across the board, and there's a reduction in the administrative burden. In November, we took a hard look at the all-payer model and really highlighted some need for improvement. We identified critical areas such as increasing the share of commercially insured payments. We wanted to see healthcare providers like Blue Cross Blue Shield Vermont and MVP include more fixed payments in their ACO contracts, because since we've implemented fixed payment, prospective payments, or value-based payments in the Medicaid program, we've seen some significant slowdown in the growth of Medicaid budget. For example, we've seen an average of 1.45% compared to an average of 5.23% in the 5 years preceding to the fixed payment. We also highlighted how important it is for Medicare to move closer to the Medicaid and how it's paid. The improvement plan also addressed scale targets. And I want to talk about this a little bit because, as you saw, the scale targets, we're behind in the scale targets. These targets represent our shared goal with CMS to move away from the fee for service on a statewide basis. Unfortunately, because how the targets are ultimately defined, to me, they're unattainable, the scale targets. For instance, Medicare benefits that receive a certain amount of health services outside the state, let's take snowbirds, for example, cannot be counted for the scale, yet they're included in the denominator against which our progress is assessed. For example, snowbirds aren't they're in the denominator, but they aren't in the numerator. So we're always going to be behind in that aspect of it. And I think we're going to really focus on, with the federal government, of changing those scale targets, because I don't think anybody knew at the time what to use as a scale target, but certainly these are out of whack, and they need to be brought into obtainable scale targets. I mean, if you look at it differently,
Secretary Smith, maybe it would be good to identify the scale targets for people who don't have that context.
Sure. Can I ask you to put those scale targets back up, Nolan, so that you can see them?
Around the mental health, et cetera. Yeah.
No problem. Let me pull it up.
Suicide.
Yeah. And that way people can see it.
These?
Yeah, these are the scaled targets. You look at annual attribution with a goal of 70% of the population enrolled in the model, 90% for Medicare. Well, you can't attribute basically all the Medicare population when you don't control all the Medicare population. That's what I'm trying to say in this model. So the 90% is going to be always unattainable. And so, and the Medicare population falls in the total population. Medicare population falls in the total population. So we're looking to change those scale. And this is nobody's fault. I mean, nobody knew as we were putting the scale targets together what would be attainable, what would not. It's just we have to sort of fine tune those scale targets as we move forward. And that's what I've been talking about in terms of the scale targets. One of the things that I look at is how many people are in the model. And if you look at how many people are in the model, we see that 90% of eligible providers are participating in the model. That's a key metric for me, at least. One of the things that just recently was pointed out, and it was in the auditor's report, that the operational costs for OneCare Vermont are too large and that our Medicaid program is paying disproportionately. Although it's really important to look at these costs, and we always do, they are just, I just want to put this in context, they are a fraction of the overall healthcare cost and a small portion of the Medicaid spending. And I did go out and look at some of the other states and what they're spending. Over a 5-year period, New York State, for example, has investments in health system transformation equal to 8.4% of its annual Medicaid spend. Massachusetts is 9.2% of its total annual Medicaid budget, and in ACO and transformation programs. And Vermont is 1.8% of gross federal and state annual Medicaid spending in reform. I don't want to minimize this, but at the same time, I want to put it in perspective. I just want to also mention that the state portion of the Medicaid investments is $9.2 million, roughly about a third of the dollars identified in that report. But again, I want to point out that the model isn't working perfectly. We have seen that that the spending still remains in fee-for-service, growing faster than the fixed prospective payment, and we need to move faster to bring more payers along with setting the price for healthcare services in advance and sticking to that price. Like I said, I'm committed to the making sure that we have value-based payment. I think I'm committed to making this work instead of sort of jumping to the next thing, to the next thing, to the next thing, but making things work. Oftentimes that's the harder part. So with that said, I'll turn it over to Ina, who has a few slides to go through the walk through the interaction between the 1115 timetable, the global commitment timetable, and the all-payer model timetable. Ina, can you just quickly? And I kept my voice through the whole thing, barely.
Thank you.
Thank you. And good afternoon again. In this first slide, I wanted to review with you the timeline for the global commitment renewal and share with you some of our progress in this process to date. We did post the proposal for the global commitment renewal in May, and have been receiving and responding to that public comment from the period of May running through this current date. With those comments in mind, we will make any modifications to the proposal and submit a formal waiver application by June 30th. So during this week, we will submit our formal waiver application to the federal partners at the Center for Medicaid and CHIP Services. From there, we will enter into a formal negotiation period. And we do want to note and make sure that it's clear that because CMS is experiencing a backlog due to a change of administration and also because of COVID-19, we do want to highlight that our approval may be delayed from our preferred approval date, which would be the conclusion of our current model agreement, the conclusion of our current global commitment agreement, which ends at the end of this year, December 31st, Ideally, we would like to enter into January of 2022 with a completely renegotiated and signed 1115 waiver program for our state Medicaid agency. However, we do need to take into consideration these factors at the federal government that may cause some delay to that being a fully complete negotiation by the end of the performance year for the demonstration. I also wanted to spend a little bit more time with you talking about some key features of the proposal that we're putting forward to the federal government. We are proposing that DVA, the Department of Vermont Health Access within the Agency of Human Services, transition to a risk-bearing Medicaid managed care organization. Within our state structure, the Agency of Human Services is the single state Medicaid agency, and the Agency of Human Services through this arrangement would have an agreement with the Department of Vermont Health Access to administer the Medicaid program in partnership with the operating agencies, including departments, including DAIL, DMH, VDH, ADAP, and DCF. DVA will function in our proposal. DVA will function as a public state-run Medicaid MCO and will be subject to all federal Medicaid managed care regulations. AHS will pay DVA a monthly per member per month capitation rate for each Medicaid enrollee, which will include all Medicaid services. DVA will manage the spend within this capitation rate, working closely with the departments to ensure that the departments are working closely with the departments who have the population-specific expertise. And like a commercial managed care plan, DVA will have flexibility in how it uses its profits. In our current waiver construct, we think of the difference between what we would have spent and what we are spending under the capitation as a place to make investments. As a formal managed care organization regulated by MCO rules by the federal government, those investments are called profits. Unlike a managed care plan, which many managed care plans are contracting in other states with Medicaid agencies, unlike these commercial managed care plans, DVA will use all of this profits to reinvest in the people of Vermont through reforms and initiatives that advance whole person health. There's a chief difference in our proposal and the way that managed care organizations operate in much of the United States and other Medicaid programs today.
Before you proceed, let me, we have a question. Senator Kitchell.
Thank you. We have risk-bearing, a proposal here to transition to risk-bearing. I think the secretary said, well, we're putting ourselves back to where we were. In the meantime, we also have the ACO, which is a risk-bearing entity. And I'm just wondering if you could distinguish between the risk-bearing status of what you envision here for DVA relative to what is embodied in the risk-bearing of the ACO. We're using that term for both entities, and I would find it helpful if you could clarify what risk is being experienced and how you distinguish between DVA and the all-payer, OneCare.
If my colleague who is sharing the slides wouldn't mind skipping to the last slide in this deck. Thank you.
Well, if you want to wait and hold the question and go through sequence, that's fine. But because it appears that you're anticipating this question. And I didn't get paid to ask it. So, so if you want to keep going in sequence and you're going to cover it later, that's fine.
This slide is actually in the deck for reference purposes, in anticipation that we might have a question of this nature, but it's not a part of the sequence of the presentation, so I'm happy to talk about it now. This slide is pretty busy, but at its core, it's describing a relationship between the Agency of Human Services and DVA as the MCO. And I will say that this relationship is really similar or even the same as the relationship that exists today between AHS and DVA. The key difference in what we have today and what we're proposing is we're proposing that DVA be recognized as a managed care organization by the federal government rather than as a prepaid inpatient health plan. In being recognized as a managed care organization, then DVA and the Agency of Human Services have more flexibility and potential to continue with the very important investments that we've been making through this model, rather than being subject to that investment capacity being eroded over time. A commercial Medicaid managed care organization has the full flexibility to use any profit that it generates at its discretion, or with much more discretion, I suppose is the way to frame that. So while we are proposing this construct and we would like to be regulated and afforded the flexibility of a commercial managed care organization, we really are seeing this model working very much as it does today. So today, the AHS and DVA have an arrangement where DVA is responsible for the spending under the capitation rate, and then DVA uses the all-payer ACO as one of its strategies for moderating healthcare cost growth by the Department of Vermont Health Access as a healthcare payer transitioning risk to an accountable care organization. That is one strategy that the payer can use to manage within a rate. Does that help to answer the question? I can't see faces, so I apologize.
Yes, and I assume we'll have obviously being able to look at the slides in greater detail later will be helpful. So thank you. You've answered it.
In addition to the core of our proposal, which is to be recognized with the Department of Vermont Health Access as a managed care organization, we are also proposing some new initiatives where we're seeking federal authority. These authorities that we're seeking from our federal partners could be used by the state to provide some additional flexibility, as well as securing federal Medicaid participation in new initiatives. I'm highlighting a few of the new initiatives here for your consideration. The first new initiative that we are proposing is to obtain federal matching funds for services provided to incarcerated adults 90 days prior to their scheduled date of release. AHS has made this proposal to allow for the expansion of coverage to inmates to support a more strategic team-based approach to identifying an individual's goal across a spectrum of health and social determinant of health-related needs, establishing a plan of care to meet those goals, and establishing connections with key community partners to participate in or lead in an individual's care team, with an individual being covered through Medicaid prior to release. This creates an opportunity for a more seamless transition of care when the individual would be covered by Medicaid after release as well. Again, this is an authority that we are seeking, and we would need to do work in order to coordinate this activity and to activate it all three initiatives are authorities that we are seeking and will require policy development and consideration prior to implementation. We're also proposing a new
I think you're good.
Just a quick question on
Oh,
that.
Okay,
Yeah, it's Senator Lyons, Jenny. Just very quickly, how will this request, this will increase our funds. So will it increase our cap? So we're adding in 90 days of coverage for incarcerateds theoretically. And so that would be additional funds available overall. That's a question.
Yeah, that would be what we would try to negotiate. We would try to include all of these with a higher cap, Senator.
Okay.
Ms. Backus, you said that there were 3 proposed, well, I think you actually said there were a number, but you referenced 3, and I'm seeing 2 on the slide.
There is a following slide that I will speak to as well. My apologies. We're also proposing to create a new eligibility group for uninsured or underinsured Vermonters between 133% and 225% of the federal poverty level with a substance use disorder. This would grant access to a more robust set of substance use disorder treatment benefits, such as peer supports, skilled therapy services, crisis supports, and residential treatment. Vermonters currently receive these services through a combination of Medicaid investment funding and block grant funding. This proposal will help us to preserve Medicaid investment funding because it would be an explicit and new expenditure authority within our Medicaid program. Again, in consideration of this proposal, we are looking for the authority. We are also looking to negotiate a waiver for the entire package that would have the most preferential trend rate for the state of Vermont. And all of these will be factored into our discussions and negotiation with federal partners. And on the next slide, I will describe the final proposed initiative, which is the authority that we're seeking for a permanent supportive housing program for adults who are enrolled in Medicaid and meet health needs and risk-based criteria. This permanent supportive housing benefit would address the full range of pre-tenancy supports, tenancy sustaining services, and community transition services for Vermonters with intensive service needs. Currently, we offer programs in the Department of Children and Families, Department of Mental Health, Department of Corrections, and Department of Health that offer housing-related services to certain populations, but these programs alone do not meet the intensive supporting housing needs of all Vermonters who are eligible for HUD vouchers due to the program eligibility criteria and separate targeting and prioritization for each of those individual programs. Many of these programs are funded through Medicaid investments, and this request will provide Vermont with, again, explicit expenditure authority to deliver these services, rather than these services being delivered only in the event that we have the availability of investment or profit dollars to cover these services. We anticipate that we would need to develop an operational plan and have that plan approved to CMS prior to any implementation of this initiative. And we would be seeking substantial stakeholder participation in a planning process, as well as undertaking the policymaking process at the state level.
So if I may ask a question.
Rep. Lippard.
Yes, so something you just said, it's clear then that this is trying to move some of these initiatives out of current global commitment initiative status into a specified Medicaid authorized Medicaid authorization for services. Is that's one of the keys that I'm hearing?
Yes.
And so that it doesn't become dependent on access to the global commitment investment situation. But is it also anticipated that it is also an expansion of the current range or amount of service that is currently provided through the investments? That I'm not clear on.
Yes, there are some scenarios where we are proposing expanding as well. Yes.
Representative, it gives us the flexibility to expand.
Okay, which might at some point require additional state dollars to pull down the federal match. Would that be also the case?
If I may, Sarah Clark, the Chief Financial Officer, I think that it may potentially require additional state dollars. That would be part of the operational plan that Ina Backus referenced, though we would be looking at existing investments to see how we could leverage those existing dollars before requesting additional state funds.
Yeah.
Mary, I've got a follow-up question.
Please, Rep. Pugh.
I am looking at the investment expenditures that we were directed to earlier. And I'm wondering which one of these are you trying to, is this anticipated to move out of those investment expenditures? For instance, whatever is Return House or Northern Lights, these were all transitional services, some of which I believe have been unfunded for this year. So are you anticipate funding them now through this, or are we? So I guess, can you give us a list, if not now, but later, what are the investments that you are moving around as it relates to supportive housing and transitional housing?
We can do that, and we can certainly share that with you. Yes.
Can I also just say what we're trying to do here? We have two caps right now. We have investment caps, we have an overall cap. We're trying to eliminate the investment cap so we don't have those caps within a cap, that we only have one sort of overarching budget neutrality number that we have to go to. That gives us flexibility within the global commitment waiver to do what we want, instead of being forced to put things into buckets and being forced to really be restrained in our 1115 waiver. These investment caps were brought in 2016. They are very restrictive, and we're trying to get rid of them.
I appreciate that, Secretary Smith. And as I've said more than once, I'm not a money person. I'm a people person, and I'm interested in the services and what Vermonters are being served and what ones are not being served.
Thank you. I'm not sure where we are in the sequence of your presentation, but yeah. So I guess I'd like to jump in here also. Why did you choose this set of initiatives or investments as opposed to everything else that you could have chosen? Why are you using these? So the housing, the DOC initiative, and whatever the third was.
The new group for SUD.
Yeah,
Again, these are authorities that we are seeking, and so that we can have the flexibility to potentially use these authorities in a new waiver construct. They would be in certain cases subject ultimately to appropriation and would need to be developed with the proper policy design process for each that are being proposed. They are being proposed for a variety of reasons, to include the input from the departments at the Agency of Human Services in this process, as well as stakeholder input that we have received over time to indicate that these are particular areas where improvement could be made, where, for instance, in the benefit for 90 days pre-release, where we have seen that the transitions between the corrections setting and the community setting are not always ideal, particularly with respect to how healthcare services can be accessed during that very critical time. And so these proposals are made taking that feedback into consideration.
And I would just remind the committee also that these are additives. We will negotiate, try not to take anything away. We want to add things to this proposal so that there isn't, and we have the flexibility, hopefully if this passes, we have the flexibility to do other things as well, depending on our overall budget neutrality gap.
Thank you. So I'm curious, so I appreciate that based on stakeholder and department input, but did you also say where are the most costly, or how can we avoid the biggest cost increases? I mean, were you looking at trends to understand which levers you could be pulling to make a difference in the long-term outcomes? So I'm back to kind of why this set of things rather than, all of the array of other things. So did you look at it through a financial, I finally got to my question. Did you look at it through a financial lens in addition to kind of the coordination of service issue?
If I may, in addition to what Secretary Smith indicated, we looked at our existing list of investments to try to identify those that we felt made the strongest case to convert out of investment and into program, to include them in this waiver application, really with the eye towards the financials and reducing that overall investment amount.
Yeah. Okay. Thank you. I'm worried that we're not going to hit our mark of being finished by 3, so I think we should let you continue, Ms. Backus.
This is the last slide, and it is a visual representation of the 2 timelines, the 1115 as well as the all-payer ACO model agreement timelines. And it's already been highlighted that these 2 agreements do work together and in coordination, especially when a state is relying on an all-payer approach to payment and delivery reform. However, they are on different timelines. So as you can see here, the preferred approval waiver start date for the global commitment is January 1 of 2022, consistent with when the demonstration is slated to end. And the all-payer model agreement is slated to end its performance period at the end of 2022. And we are showing here on the timeline at the very bottom of the timeline, the last group of arrows, that our preferred start date for our preferred approach would be to provide for a 1-year extension and extend the model to 2020 through 2023, and then begin a new agreement or subsequent agreement in 2024. And that's what we wanted to demonstrate here, is the way that these 2 are lining up. We're very much, as I reviewed, active in the 1115 renewal process with the formal submission of the application. happening this week, and with some preliminary discussions that have already been underway, and the formal negotiation to happen between June and we hope finalized in December of this year.
Okay, thank you. Thank you. It's an awful lot to take in a very short period of time. Thank you for providing us with that. I know that some of folks have a time constraint, and I'm watching the clock. Board Chair Mullen and Ms. Barrett were kind enough to join us in this meeting, and I just wanted to give you perhaps a few minutes to engage us in this conversation, and then let's see what sort of questions we may have and where we'd like to go. Thank you. Mr. Mullen?
Thank you, Madam Chair. And basically, when we first got the invite from Steve Klein, he just asked us to be available. So if you don't have the time to go through our slides now, you already have them. You could go through them then. It's up to you if you want us to walk you through those slides or if you want us to just take questions.
I'm just very aware of timing issues, and I want to stick to that schedule. So maybe we can take questions and have a general conversation and invite you back in. We tried to do, not surprisingly, too much in a short period of time. So let us just pause for a general conversation. Senator Kitchell?
Yeah, as I'm thinking about what Kevin's talking about, it's so hard. We move back and forth between the all-payer model and the global commitment waiver. And the waiver is really what we're focusing on now.
Okay.
And if I remember correctly, under the Green Mountain Care Board is a signatory to the all-payer model. So your role, I just want to be clear, is as signatory to the all-payer model. And so as we're talking about what we have to move out first, which is renewal of the global commitment or an extension, and what's being prepared is there's not a formal connection to the board in the same way there is for the all-payer model. Is that correct, Kevin?
That's correct, Jane.
Okay.
And basically, Secretary Smith and Director Backus will be before our board Wednesday morning at 10 o'clock and briefing us a little bit on what their thoughts are. I have been briefed all along. Again, I'm just one member of a 5-member board, so I don't want to speak on behalf of the whole board, but everything that the Secretary has said makes some sense. And especially due to the pandemic, there was not the ability to engage the stakeholders in a meaningful way. And so I think that a 1-year extension of the agreement makes sense, which is what he said earlier today. And, that's something that the board will have to actually vote on. But it's something that, given what has occurred, it makes a lot of sense. And I was really pleased also, just let me throw this out there to put it in your minds, that what the Secretary had mentioned about looking at the scale targets, because that report we're sending to the federal government Wednesday as well. And it's no surprise that we did not meet those scale targets. And that has been, we've been behind, but we've made incredible progress in recent history. And the report that goes in 2 days is for year 20, not year 21. And in 21, we picked up Rutland Regional and their attributed lives, and we picked up the state employees and their attributed lives. So there's significant progress that's being made. And I also agree with the Secretary on his point that we shouldn't just quickly abandon something because we haven't reached our targets. And I think that at this point, Jane, I would say that there's nothing that the secretary or the director said that would cause me alarm, or I think my colleagues at the board.
Okay, thank you. Representative Ansel?
Thank you. I'm now sufficiently confused to ask a question. So I am unclear what the board's role is with respect specifically to the waiver.
Very little.
That's right.
Okay.
Yeah.
That was my
So
question.
the conversation you just
Focusing
had,
on the waiver, then you really don't need to hear from us today.
okay.
We can be a future visit.
And then the other question, which I'd like to explore at a future visit, is what does it mean to say that the board is a signatory to the all-payer model? What in terms of your role generally as a regulator and your role as a signatory, sort of how do those things work? And we don't have to have the conversation here now, but I'd like to have it at some point.
Sure, look forward to it.
Great, thank you.
Thank you. Senator Lyons?
Good. I think that Representative Ansel got to my comment, which was, I think it may be helpful to have the board come in and talk about its role within the all-payer as well as for the ACO, because it does get to be pretty complex sometimes for some folks. And then we should probably look separately, as Representative Ansel was thinking, at the waiver, to look at the waiver separately and what role we play and what role we might have in influencing at all the waiver requests. So that's it. So thank you. I didn't have any other questions
you.
at this time. Thanks,
Well,
everybody.
And here's where I'm a little bit lost in terms of what our legislative role or potential role is with regard to the global commitment waiver, which is required to be submitted, and the negotiations will be begun in moment. It's due the end of June, and it sounds like you're on schedule for this. And I'm thinking about what our role is appropriately played out there. Can anybody help me with that? If not, I can move on. We have other hands, but
I'm happy to try. I think my internet connection seems to be unstable, so I don't know.
I thought it was my connection. It may be
no, mine just flashed up with the words.
Yeah.
I think there's thunderstorms in the area.
Yeah.
So I didn't get all of your question, but I think if the question is what is the role for the legislature at this point in the global commitment waiver renewal process, I think it's really oversight and advisory. That there was a requirement that that there be legislative approval before AHS could proceed with the renewal process, and the legislature gave that in the Budget Act, along with some language about trying to.
Whoops.
Oh, we've lost.
Yeah, there are thunderstorms over here. But so Jen, I think we've lost
flexibility on the investments. My connection.
Yeah, we're losing you. Why don't you turn your camera
off? Oh, great idea. And I just changed my network, so maybe that'll help too. So I don't know where you lost me, but you gave the approval that they needed in the budget bill, and you gave them some direction about trying to increase flexibility with the use of the investment funds. So, I mean, as the legislature, your role is generally limited to what you do through legislation and what you do through the budget specific, for the money pieces to fund what you do in legislation or what others want to do with flexibility you've provided. So between now and when they negotiate, finalize the negotiations, to the extent that happens before you're back in session, that may be the extent of your role, is to understand what's going on, and for AHS to know that if you're unhappy with something, you can always come back in the future legislative session and change their authority or change or direct them to seek changes from CMS.
Okay, thank you. That's super helpful to me. Senator Westman?
So my question is kind of a follow-up on what Representative Hooper laid out. This was a good presentation to lay the groundwork about where we've been, what it is. The real question is in the negotiation of the waiver, which is really the responsibility of the administration with the feds. How can you report back to us the problems you're having, because you suggested you wanted to, that there would be an effort in some areas to ask for more flexibility and expansion. How will the administration feed back to at least this committee information about where the decision-making points are, what the problems you're having, and what pushback you're having from the feds, so we at least know where what's happening in those negotiations. And we have to rely on the administration to do that. So how would you see that working?
Well, Senator Westman, I'm sorry.
Both, I really don't care, you know.
Going back to my days in 2005, I remember we kept the committees fairly informed what was happening through, and I'll make that commitment to do that, you know, making sure you know where we are in the process, some of the things that we're having issues with or agreement with as we move forward. But I'll make sure this committee is alerted to those things along the way.
Thank you, because, you know, I suspect mostly what we're going to try to do is cheer you on in trying to get more flexibility in this and get us more funds. So, but I think it will be helpful if we were brought along in the process so we knew what the friction points were.
Yes, of course. Thank you. Secretary Smith, can we see the application? Is this information posted somewhere so that we can see the public comments and have a sense of the conversation?
I believe so, Ina. I just want to make sure I'm saying this, the right thing here.
Yes, the proposal is public now and is open for comment. And I don't want it, I think that we can provide a summary of public comment and our response to the comments. I believe that is something that we can provide.
Yeah, okay. But so somewhere at the AHS website is information, we can find this. Could you perhaps send us a link to where this is?
Yes, I believe it has been posted to the HROC website.
Okey-doke, thank you. Senator Kitchell?
Yeah, my comment is related to the public input and the comments and the extent to which that has influenced the application. To be honest, we're already starting to get communications around concerns, should the long-term care incorporation. And so it's very helpful to know, were those concerns raised, considered, modified, included, etc. So maybe that would also be helpful, rather than our reading through pages, the extent to which that comment period and process influenced the document or the application that you're submitting. And again, this is on the global commitment, because it's so, it's so easy to tie the two, and you do in that final saying, well, this will be leverage for the, you know, the APM. And to me, one of the fundamental questions we have to say is, if we move to this risk bearing and Medicaid management, et cetera, what we get over and above that, and this gets into overall healthcare transformation. What do we get from the all-payer model? And I think that needs to be people really need to see. That may take time, it may take investment, but what is to be gained that, otherwise wouldn't happen. I'll give you an example. One of my favorite things I've been after for years is it would be really nice if we had a common formulary across all payers. Providers would love it. It would negotiate, et cetera, much different volumes, those kinds of things. It's just an example of where, when you bring it all together, then it would have a beneficial impact in terms of consistency, not having to look at, well, you're this payer, you get this, et cetera. So I think that's what we're struggling with is what will we get? It's not a debate around fee for service versus value. That's not the issue here at all. But it's how we can really understand this within the framework of sometimes what we read in the paper, comments that are made, or even through the public comment process that you're having to engage in as part of the waiver. So I just wanted to say that would be helpful if we had that information, because it could very well mean an issue that you've given a lot of thought, made a decision. It's just, well, here's another avenue to raise that concern.
Okay.
When we submit formally the application, that submission will be accompanied by the responses to the public comment. And we will also have a summary of the public comment available. And we will make sure to provide you with direct links or attachments containing that information.
Okay, thank you. Representative Lippert?
Well, I was just going to say, I'm hearing from some folks saying they cannot find the links to the application and the public comments, et cetera. So what I just heard, you will be provided with those directly and make sure everyone can access those.
Thank you. And to be clear, are you on schedule to submit this application at the end of June? So this week, yeah.
Yeah, we are on schedule. Yeah.
Okay. Okay. Folks, we're a wee bit over time. I think we've accomplished our goal of getting a very basic understanding of where we are. I think we'll have to put our heads together to think about kind of a next meeting and what we've outlined some information that we'd like to receive, but I think it's a stay tuned, and we will organize an ongoing conversation about this. Secretary Smith, I really hope you are just talking too much and not getting sick. So please be well. And I just want to say thank you both to our colleagues, but also to all of our other colleagues in the executive and over at Green Mountain Care for joining us. Thank you very much for being part of this discussion. And with that, I would ask